Now starting with depolarizing muscle relaxant. Now starting with what, guys? Depolarizing muscle relaxant. In depolarizing muscle relaxant, you are having two drugs, but you have to just remember one. Why? Because one drug called as decamethonium is not used. Hence, in depolarizing, the one-man army that is there in depolarizing is what? It is equal to the, it is this one-man army of depolarizing. It is usually heavier than the non-depolarizing. What is that drug? It is succinylcholine or succinylcholine or Scoline. It is called as succinylcholine or succinylcholine or Scoline. So in depolarizing, only one-man army that we need to remember is succinylcholine or succinylcholine. We can just tell it as Scoline also. We'll tell it as Scoline. Now, what is the introduction of this drug? This choline is made up of two molecules of acetylcholine. It is regarded as the fastest as well as the shortest acting muscle relaxant. This point is very, very important. Fastest as well as the shortest acting muscle relaxant. Guys, if you keep a race between depolarizing and non-depolarizing and see who is winning, it is always the depolarizing who always wins. The fastest acting muscle relaxant is the depolarizing. The shortest acting muscle relaxant, again it is depolarizing, right? But guys, in the MCQ they are asking you the fastest acting non-depolarizing. What's your answer? Fastest acting non-depolarizing. What's your answer? In the MCQs only they are telling non-depolarizing drug mein which is the fastest. Which is the fastest? Rockstar is the fastest. Rocuronium. If the MCQ is asking you the shortest acting non-depolarizing muscle relaxant, then what's your answer? He is asking only about non-depolarizing, not about depolarizing. So the answer is Vecuronium. The answer is Vecuronium. But the MCQ is asking you the shortest acting muscle relaxant. Did he mention there depolarizing or non-depolarizing? No. If he is not mentioning, that means he is basically racing the two, depolarizing and non-depolarizing. And in overall category, which is the shortest as well as fastest, it is always the depolarizing drug which is called as Scoline. SCH is the short form of Scoline, right? So it is the fastest and the shortest acting muscle relaxant with the onset. Why it is the fastest, guys? Why? Because it is having a fast onset. It's having a fast onset. Within 30 to 45 seconds, the muscles become relaxed. Next is duration. After giving this drug, why it is called as a shortest? Why? Because it is having a short duration. How many minutes, guys? It is having a duration of 3 to 8 minutes. It has a duration of 3 to 8 minutes. Okay. So we were discussing about the Scoline. The onset is 30 to 45 seconds and the duration is 3 to 8 minutes. So now, guys, we'll discuss what happens to the patient after receiving Scoline. Remember, guys, Scoline is a depolarizing muscle relaxant. My question to you is, before giving, my question to you is, for depolarization, for muscle relaxation to happen, what should happen to depolarization? There should be depolarization or there should be blockage of depolarization. If you want to relax the muscle, what should happen to this thing called as depolarization? If you want to relax the muscle, there should be no depolarization. All non-depolarizing muscle relaxant will block the depolarization. Whereas the depolarizing muscle relaxant called as Scoline, what will it do? Scoline, when you give it to the patient, in the initial seconds, it will cause what? In the initial time after giving Scoline, initially it causes what? It causes depolarization. It causes depolarization, and after some time it causes hyperpolarization, and after hyperpolarization it causes then blockage It causes then blocks or it blocks the depolarization. It blocks the depolarization. Non-depolarizing muscle relaxant directly blocks the depolarization, whereas depolarizing muscle relaxant first blocks the depolarization, first it causes depolarization, then it causes hyperpolarization, and then it blocks the depolarization. And basically, if you want to eat food, you can eat the food like this, or you can eat like this also, but no one eats like this. But our depolarizing muscle relaxant likes to eat the food like this. Imagine this is a depolarization that needs to be blocked. Non-depolarizing directly blocks the depolarization, whereas a depolarizing muscle relaxant first it causes depolarization, then hyperpolarization, then it blocks the depolarization, right? As it is causing depolarization and hyperpolarization in the initial time of Scoline administration, what will happen to the muscles of the patient? In the initial time, the patient muscles will contract. The patient's muscles will contract. So, depolarizing muscle relaxant first, it causes muscle contraction, then it blocks depolarization, and then muscles will become relaxed, right? So guys, this was regarding the introduction of the depolarizing muscle relaxant, right? So we are discussing still about what? Scoline. Regarding Scoline, what we need to remember, it's a depolarizing muscle relaxant that is regarded as the shortest as well as the fastest acting. Why it is shortest? Why? Because short duration. Why it is fastest? Fast onset. The onset is 30 to 45 seconds, hence it is called as the fastest acting. And the duration is 3 to 8 minutes, hence it is regarded as the shortest acting, right? Now, where is the Scoline metabolized? Metabolism of Scoline. Come on guys, where it is metabolized? Scoline is metabolized in the same place where amino esters were metabolized and Vecuronium was metabolized. The Scoline is metabolized in the plasma by plasma pseudocholinesterase. By plasma pseudocholinesterase or plasma pseudocholinesterase or plasma esterases, right? That's the metabolism. Next, there is a condition called as Scoline apnea. SCH is Scoline apnea. What is the Scoline apnea? First, we need to understand what is Scoline apnea. Imagine guys, there is a patient who is posted for some surgery under general anesthesia. If I give Scoline to the patient should recover within how many minutes? Within the duration. The duration is 3 to 8 minutes. The patient should recover within 3 to 8 minutes after receiving Scoline. But what if the patient does not recover in 8 minutes? You wait for more 20 minutes. If he doesn't recover in 8 minutes, you wait for at least 20 minutes. What if he doesn't recover after 20 minutes? First of all guys, how will you come to know that your patient has recovered from the effect of Scoline? Either the patient will move or either he will breathe spontaneously. If he breathes spontaneously, that means his muscles are contracting and relaxing, right? So remember guys, this muscles should contract or this patient should recover spontaneously within 8 minutes. If the patient is not recovering within 20 minutes of Scoline administration, such a patient is land up into an apnea condition called as Scoline apnea. What is Scoline apnea guys? Even after 20 minutes of Scoline administration, if the patient doesn't recover, it is called as Scoline apnea, right? Doesn't recover, or if the patient does not breathe spontaneously. If the patient does not recover or if the patient does not breathe spontaneously, it is called as Scoline apnea. What is the cause of Scoline apnea guys? What is the cause of Scoline apnea? The cause of Scoline apnea is related to the metabolism of Scoline. Where is the Scoline metabolized? In the plasma. if a person is having deficiency of pseudocholinesterase or atypical pseudocholinesterase, he is not having enough pseudocholinesterase to metabolize the Scoline properly, the action will be prolonged. The action of Scoline will be prolonged for a long time, right? The cause of Scoline apnea is deficiency of pseudocholinesterase or atypical pseudocholinesterase or atypical pseudocholinesterase. That is the cause of Scoline apnea. That is the main cause of Scoline apnea. How will you come to know this patient is having deficiency of pseudocholinesterase? If you guys stress into your mind, you will get the answer. We have discussed something in the local anesthetics, right? Which is the longest acting local anesthetic, Dibucaine. I told you Dibucaine is not used for anesthesia purpose. Dibucaine is only used for a test. What is that test? Dibucaine number test. So for diagnosis of Scoline apnea, you can go for a test. What is that test called as? Dibucaine number test. Dibucaine number test. What do you do in this Dibucaine number test, guys? What is being done in the Dibucaine number test, right? So now guys, look over here. Dibucaine number test detects the atypical pseudocholinesterase or pseudocholinesterase deficiency. There have been a question on Dibucaine number test. Dibucaine number test. What was the question for Dibucaine number test? The question was, how is the test done and what are the results of this test? When you do a Dibucaine number test, the results might come as, first we'll compare in a normal person what happens, then we'll compare in a patient who's having deficiency. Okay? In a normal person, basically when you give Dibucaine, Dibucaine detects the pseudocholinesterase deficiency. Na? When you give Dibucaine to a normal person, what will happen to the pseudocholinesterase levels? Dibucaine normally inhibits the pseudocholinesterase levels. Imagine guys, I am a person who is rich in pseudocholinesterase. I am a normal person who is having much amount of pseudocholinesterase. When the thief called as Dibucaine goes in my body, Dibucaine will be a thief, right? What will it do? When it goes into a body of a rich person, what will it do? It will loot much amount of pseudocholinesterase or it will inhibit much amount of pseudocholinesterase. As I am having 100% of pseudocholinesterase, if I receive Dibucaine, what will happen to me? More than 80% will be inhibited. More than 80% will be inhibited. So Dibucaine number test means if you give Dibucaine to a normal person, after giving Dibucaine to a normal person, how much will be inhibited, guys? More than 80% of pseudocholinesterase will be inhibited in a normal person. If you give Dibucaine to a patient who is having Dibucaine deficiency, less than 20% will be inhibited. How much will be inhibited? Less than 20% will be inhibited. Now guys, I will give you an example. Imagine there is a thief. Okay? He is standing in front of there is a thief or a burglar. He is with his bag. He is standing in front of two houses. One is the house of an MLA or one is the house of a politician. Other is the house of a beggar. Where do you think that he will go? He will choose always the house of a politician. Why? Because they are having good amount of money and all. Right? Why? Because he knows if I go to a politician house, if I go to a rich man's house, I will have a very good amount of loot with me. But if I go to a beggar's house, I can't loot anything. Same happens with Dibucaine. Imagine Dibucaine is a thief standing with his bag. He is in front of a normal person having 100% of pseudocholinesterase, and he's also in front of a person who's having pseudocholinesterase deficiency. So if I give Dibucaine to a normal person, how much will be looted from him? 80% of his wealth or 80% of his pseudocholinesterase will be looted for some time only, for some time. Whereas if I give Dibucaine to already deficient patient, how much will be inhibited? Less than 20%, right? This is Dibucaine number test, guys. Dibucaine number test. If you give in a normal person, more than 80% will be inhibited. If you give Dibucaine to a person who is having deficiency, patient with deficiency, how much will be inhibited? Less than 20% will be inhibited. That's regarding the Dibucaine number test. Now again, coming to Scoline apnea. Imagine you have given Scoline to a patient, and after giving Scoline, you waited for 8 minutes, he did not move. You waited for 20 minutes, the patient did not move. Now the patient had landed up into what? The patient is in Scoline apnea condition. The patient is now into Scoline apnea condition. How will you manage this Scoline apnea? How will you manage this patient's Scoline apnea? How will you manage, guys? Will you remove the tube? Remember, after giving Scoline, you have intubated the patient and now you are waiting. Will you remove the endotracheal tube if he is not breathing? No. The main management of Scoline apnea is what, guys? What is the main management of Scoline apnea? The main management of Scoline apnea is, what's the main management? Intubate. Yani patient is already intubated, no? Ventilate the patient till he recovers. Ventilate the patient till he recovers. The main management of Scoline apnea is ventilate the patient till he recovers. Apart from ventilating the patient, what else we can do in Scoline apnea? What are the other things that we can do in Scoline apnea? Why did the patient have this Scoline apnea? Why? Because the person was having pseudocholinesterase deficiency. Give some pseudocholinesterase to the patient. That will be simple, no? But where is pseudocholinesterase present? In the plasma. You can't give pseudocholinesterase directly, but what you can do is, you can take some other patient's plasma and give it to this patient, right? So, other supportive management includes what? Other supportive management of Scoline apnea includes what, guys? You can give FFP. What is FFP? Fresh frozen plasma. Fresh frozen plasma you can give. Apart from FFP, what else you can give to the patient? FFP you can give to the patient. Apart from FFP, patient was having deficiency of pseudocholinesterase. That's why Scoline apnea was seen. So what you can do? You can change the whole blood volume and replace with the blood volume that has pseudocholinesterase by dialysis or plasmapheresis. By dialysis or plasmapheresis. That is supportive. But the main management of Scoline apnea is what, guys? What is the main management? The main management is ventilate the patient till he recovers. Ventilate the patient till he recovers. Right? So guys, remember, don't tell me that neostigmine should be used. Yes, we know that neostigmine is a reversal agent against the muscle relaxant. But from now, remember, neostigmine is a reversal agent for the muscle relaxants which are being metabolized in the liver and excreted through the kidney. Neostigmine is not used for the muscle relaxants which are having other metabolism than liver and kidney. Right? So neostigmine, will you use for the reversal of Scoline effect? No. Will you use neostigmine for Cisatracurium? No. Why? Cisatracurium also has nothing to do with the liver. Atracurium, we can't use neostigmine. So neostigmine is not used for what muscle relaxants, guys? Neostigmine is not used as a muscle relaxant for the muscle relaxants called as Atracurium, Cisatracurium, Scoline and Vecuronium. Why? Because Atrac and Cisatrac both are metabolized by Hoffman degradation, whereas Scoline and Vecuronium are metabolized by plasma PSCH. PSH pseudo, CH is cholinesterase. Right? So this is regarding what? Scoline. So Scoline should not be used as a reversal agent for, neostigmine should not be used as a reversal agent for these muscle relaxants, Atracurium, Cisatracurium, Scoline and Vecuronium. Coming to the side effects of Scoline. Scoline will also cause some histamine release. Apart from before going to the side effects, guys, if you want to store Scoline for a longer duration, if you want to store Scoline, store Scoline for a longer duration, you have to store Scoline at 4 degrees Celsius. When you store it at this temperature of 4 degrees Celsius, you can store it for 1.5 to 2 years. You can store it for 1.5 to 2 years, right? So remember guys, Scoline also causes histamine release. Coming to the side effects of Scoline, which is again a very important topic, right? Side effects of Scoline use. So guys, I'll tell you the side effects with a case so that you can remember the side effects. Basically, it was my 10th day of joining the anesthesia department. I went into the operation theatre. My senior was giving general anesthesia to the patient. As he was giving general anesthesia, he asked me questions, right? Asking questions is the best thing, guys, to get knowledge. Not only in our field, you have to ask questions everywhere, in every sector. So anyways, guys, we are talking about anesthesia. So my senior had this habit of asking questions. He was asking questions to me, right? So from that questions, I can easily still till date I can recover till date I remember the side effects. So first question what he asked is, he was giving general anesthesia. So before giving general anesthesia, he asked me, what are the 4 phases of general anesthesia? I answered him. There are 4 phases of general anesthesia where there is pre-oxygenation, induction, maintenance and reversal. Now you are also answering, no? So I also answered the same. The next thing that he asked is, okay, now I am giving an IV, now I am giving general anesthesia, pre-oxygenation is done, I'll go for the induction phase. As he was going into the induction phase, he made the patient unconscious by using a yellow amorphous powder. Come on guys, what comes to your mind? A yellow color powder, what comes to your mind? Yellow amorphous powder is sodium thiopentone. Sodium thiopentone is used to make. So he asked me, he just showed me this vial, yellow amorphous powder, and he told me, what is that? I told what? It is basically sodium thiopentone. He gave sodium thiopentone. After that, he gave some muscle relaxant. He did not tell me what muscle relaxant he gave. He gave some muscle relaxant. The shortest and the fastest in overall category is what? Scoline. So in my mind, I made the answer that he might have given Scoline. After giving Scoline, now he told me to observe the patient. I was observing the patient. What I saw during observation, I saw that the patient is having this movement of the hand. This movement of the hand and leg. What is this movement of the hand and leg called as? This is called as fasciculation. This is called as what, guys? Fasciculation. So he asked me, why is the patient having fasciculation? I told, sir, you have given thiopentone, it won't cause any fasciculation. Then you have given, then you might have given Scoline to the patient. But Scoline is a muscle relaxant. How will it cause fasciculation? But still I told what? You might have given Scoline, sir, which has, that's why patient, you might have given Scoline, I answered. He told, yes, your answer is right. But I got more confused. Scoline should cause relaxation of the muscle, not contraction. Fasciculation is a sign of contraction. Then he explained me that Scoline initially, it causes depolarization, hyperpolarization, and after 30 seconds, the depolarization is blocked. Due to the depolarization and hyperpolarization, in the initial seconds of the patient will have what? Muscle contraction, which is called as fasciculation. And after some time, the fasciculation will be gone. Yes, the fasciculation were gone after some time, the muscle became relaxed, and then he intubated the patient. Now what homework he gave me, as the patient, he told me as the surgery will be done, you shift the patient to the post-op ward, and after shifting the patient to the post-op ward, go to the patient and ask the patient what is he complaining of. So in the case sheet, the first homework was, what is the fresh complaint of the patient? Second homework that he gave is, he told me to ask he told me to check the potassium levels of the patient and compare with the pre-op value. Second homework was check the potassium level and compare with the pre-op value. I went into the post-op room. I asked the patient, what are you complaining of? The patient complained of pain in each muscle of his body. I wrote in the case sheet, patient is having body pain. The first homework was, what is the first complaint of the patient? I told patient is having body pain. The second homework was, he told me to check the potassium levels. I checked the patient's potassium level, it were 5.5. Then I compared it with the pre-op value. The pre-op value of the potassium was 4.5. So what had happened to the potassium, guys? From 4.5 it had become 5.5 and the potassium levels are increased. So what I told, the patient's potassium level is increased. The patient is having hyperkalemia. The patient is mildly hyperkalemic. So I wrote these two things in the case sheet. The patient is having muscle pain or body pain. Second thing, the patient is having hyperkalemia. Then I went to what? Then I went to the senior. I told him the patient is having body pains. The senior told, why is he having body pain? I was thinking, basically the patient was posted for some thyroid surgery. So I was just thinking like this and I told my senior that, sir, this surgery was for thyroid. Thyroid surgery is a stressful thing. Thyroid surgery is a major surgery, means the patient will have a stress. Due to the stress, he might be having body pains. He told, don't answer in a lame way. First of all, it is not body pain, it is only the muscle pain. He clarified it is a muscle pain. And then he asked me, why is the muscle pain? Then I was again thinking. Then he gave me a hint. Today you saw some rapid fasciculations or contractions. Due to that rapid fasciculation or contraction, the patient is having muscle pain, he told. Then he asked me, what is the drug that causes this? Then I understood that, yes, Scoline causes contractions and fasciculation in the initial seconds. Due to the contraction and fasciculation, patient complains of muscle pain. That's why the most common side effect of Scoline use is muscle pain or muscle soreness. Muscle pain or muscle soreness. The second side effect of Scoline use is what, guys? The second most common side effect of Scoline use is the second homework that was given to me. What was the second homework given to me? My senior told me what? He told me to check the potassium levels of the patient. I checked the potassium levels, it was 5.5. I told him his pre-op potassium level were 4.5. Now it is 5.5. What has happened to his potassium, guys? What has happened to his potassium? His potassium levels increased. Why his potassium levels increased? He asked me why the patient potassium level increased. By this time I knew this guy was asking all the questions related to Scoline. I just answered what? So I told him it was Scoline. It was Scoline that is causing the hyperkalemia, right? But what he told me, he told me that yes, it is Scoline that causes hyperkalemia. He asked me how it is causing hyperkalemia. Then I was confused what to answer him. I answered him what, guys? I just told him that Scoline causes hyperkalemia, but I was not able to answer why. But he told me, you know the answer. I thought that Scoline, initially when we give Scoline, what happens to the muscles? The muscles are contracted. Due to this rapid contraction of the muscle, the potassium from the muscle is lost. That goes into the blood. That leads to hyperkalemia. That leads to what, guys? Hyperkalemia. So remember, guys, Scoline causes hyperkalemia. Scoline causes hyperkalemia. It increases the potassium by what levels? It increases the potassium by 0.5 to 1 milliequivalent. Right? So guys, we are discussing about what? We are discussing about the side effects of Scoline. 2 points are repeated over here. So just remember 1 point. The first and the most common side effect of Scoline is it causes. The most common side effect of Scoline is what, guys? It causes muscle soreness. Why is this muscle soreness seen? It is also seen due to fasciculations. Second common side effect of Scoline use is what? Second common side effect of Scoline use is hyperkalemia. Hyperkalemia. Scoline increases the potassium levels by what milliequivalent? 0.5 to 1 milliequivalent. In our case, it has increased the potassium by 1 milliequivalent. So guys, the last question that my senior asked me was, if Scoline is causing hyperkalemia and all, can we give Scoline to a patient who is already hyperkalemic? Can you give Scoline to a person who is already hyperkalemic? What should be the answer, guys? Yes or no? Answer is no. We can't give Scoline to a person who is already hyperkalemic. Who is the person who is already hyperkalemic? The person who is suffering with muscle dystrophies. Muscle dystrophies. Apart from that, the person who is suffering with burns. Right? Burns patient are hyperkalemic. Muscle dystrophies. CKD patient. A person who is bedridden, he'll be having muscle wasting. That leads to hyperkalemia. In all these persons who are already hyperkalemic, if I give Scoline, what will happen? Imagine their potassium levels pre-op will be 6. If I give Scoline, it will become 7. That can cause what? That can cause life-threatening arrhythmias, that can cause cardiac arrest. So remember guys, the most common side effect of Scoline was muscle soreness. The second most common side effect of Scoline is hyperkalemia. Right? The third side effect of Scoline use is, if I give Scoline to a patient, some of the patient will develop bradycardia. Coming to the last complication of Scoline, or the last side effect of Scoline. The last side effect of Scoline is what? It is the most dreadful side effect of Scoline, which is called as malignant hyperthermia. Which is called as what, guys? Malignant hyperthermia. Malignant hyperthermia. You guys know what is malignant hyperthermia? Yes or no? Malignant hyperthermia is what? Abnormally high temperature with sustained muscle contraction. Malignant hyperthermia is what, guys? Right. Abnormally high temperature with sustained muscle contraction is called as malignant hyperthermia. We have discussed malignant hyperthermia in local anesthetic. Which local anesthetic causes malignant hyperthermia? Lignocaine. Right. So in anesthesia, malignant hyperthermia is not a new thing. Now what is malignant hyperthermia? It is abnormally high temperature with sustained muscle contraction. But why does malignant hyperthermia happens after Scoline? If I give Scoline to 100 persons, only 2 persons will develop malignant hyperthermia. Only 2 persons will develop malignant hyperthermia. Why? Why only that 2? Why not 98? Why? Because remember, malignant hyperthermia is seen in patients who are autosomal dominant. Imagine those 2 patients were autosomal dominant. If you give Scoline to an autosomal dominant patient, what will happen? That Scoline goes in the bloodstream, goes towards a receptor called as abnormal ryanodine receptor. That Scoline goes towards the abnormal ryanodine receptors. It stimulates the abnormal ryanodine receptors. As the receptor is stimulated, that receptors releases calcium. And as calcium is released into the blood, the patient will have sustained muscle contraction, starting in what muscle? Starting in the masseter muscle. Thereby the whole body muscles gets contracted. Right? So remember guys, we are discussing about what? Malignant hyperthermia. What is malignant hyperthermia? Abnormally high temperature with sustained muscle contraction is called as malignant hyperthermia. Right? I told you it is seen due to stimulation of what receptor? It is seen due to stimulation of the abnormal ryanodine receptor. Right? It is seen in what individual? It is seen in autosomal dominant individual. Right? Now, in malignant hyperthermia, what do you see? As the receptor is being stimulated, what happens? Calcium gets released, and due to this calcium getting released, patient develops muscle contraction, starting in what muscle? Starting in the masseter muscle. Now guys, if the masseter muscle, if the body muscles are totally contracted, including the respiratory muscles, if my respiratory muscles gets contracted, what will happen? Will I take in oxygen? No. Will I exhale carbon dioxide? No. Carbon dioxide gets accumulated in the body, leads to what? leads to what? Acidosis. So in malignant hyperthermia, you will see respiratory acidosis, you will see the PCO2 values being very high. Apart from that, the patient will have an increase in temperature and tachycardia. Increase in temperature and tachycardia, right? So that's regarding what? That's regarding malignant hyperthermia. Now guys, my question to you is, in the whole topic of anesthesia, is just Scoline causing malignant hyperthermia? No sir. Apart from Scoline, there are some other drugs that can cause malignant hyperthermia. What are the other drugs that can cause malignant hyperthermia? What are the other drugs? Local anesthetic causing malignant hyperthermia, lignocaine. Lignocaine causes malignant hyperthermia. Apart from lignocaine, which muscle relaxant causes malignant hyperthermia? Commonly, the muscle relaxant that causes malignant hyperthermia is what, guys? It is Scoline. After muscle relaxant, we'll discuss about what? We'll discuss about the inhalational agents. Remember, all inhalational agents can cause the risk of malignant hyperthermia, but maximum risk of malignant hyperthermia, it is seen with an inhalational agent called as halothane. We are discussing about the triggers of malignant hyperthermia, right? Triggers of malignant hyperthermia, right? What are the triggers, guys, for malignant hyperthermia? In the muscle relaxant, it is Scoline, right? In the inhalational agent, almost all, but it is commonly seen with halothane. IV induction agents are safe, right? Next, local anesthetic causing malignant hyperthermia is lignocaine. The ones which I am ticking over here, they came as previous year's MCQs. Okay. The most common LAs, the most common local anesthetic causing malignant hyperthermia is lignocaine. The safest local anesthetic is procaine. That's regarding what, guys? Malignant hyperthermia. How will you diagnose malignant hyperthermia? For diagnosing malignant hyperthermia, we go for a provocative test, which is called as what test, guys? Which is called as, right? For diagnosing malignant hyperthermia, we go for a test which is called as provocative test. Provocative test means what? We give halothane to the patient, we give some caffeine to the patient, and then we check how is he reacting. The test is called as halothane caffeine test. The best diagnostic test for malignant hyperthermia is halothane caffeine test. And how will you treat a patient who is suffering with malignant hyperthermia? A person who suffers from malignant hyperthermia will have a sustained muscle contraction. They go by for abnormal high temperature, you can give paracetamol, you can give other antipyretics. But for sustained muscle contraction, you need to give a centrally acting muscle relaxant, which is what? Dantrolene sodium. The drug of choice for malignant hyperthermia is IV dantrolene sodium. IV dantrolene sodium. IV dantrolene sodium is a drug of choice for malignant hyperthermia. With dantrolene sodium, what else we can give? We can give the patient some antipyretics. We can also give some ice cooling to the patient so that the temperature comes down. And as the patient is having acidosis, we can also give soda bicarb to the patient. Soda bicarb is what? Sodium bicarbonate. We can give sodium bicarbonate to the patient, right? And while giving this therapy, you have to monitor the patient's potassium as well as calcium levels. Potassium and calcium levels. So remember, we were discussing the side effects of Scoline. The most common side effect was my first homework. What was the most common side effect? It is muscle soreness or muscle pain. Okay, that is seen due to fasciculation. The second side effect was hyperkalemia. The third side effect is bradycardia. The fourth side effect, or the most dreadful side effect of Scoline use, is malignant hyperthermia. Coming to the last aspect of muscle relaxant, in which they have been asking you about the causes of potentiation of muscle relaxant, which is given over here. Here it is given as causes of potentiation. What is meant by potentiation, guys? Potentiation means prolongation. Potentiation means what, guys? Prolongation. Causes of prolongation of muscle relaxant. Neuromuscular block is muscle relaxant. What are the things that will prolong the effect of muscle relaxant? We have discussed a few things, such as lithium will prolong the effect of muscle relaxant. Hence, stop lithium 24 hours before surgery. Apart from lithium, other drugs that can prolong the effect of muscle relaxant is what, guys? One is lithium. Apart from that, antibiotics, that needs to be stopped. Antibiotics have to be stopped before surgery. 2 antibiotics, not all. All antibiotics are safely given, but 2 antibiotics needs to be stopped. What 2 antibiotics, guys? Aminoglycoside and tetracyclines. Right? So what causes the prolongation of muscle relaxant? Yani ke, if you give muscle relaxant, and with muscle relaxant, if that drug is given, it will prolong the effect for unnecessarily longer period of time. What are those things? Antibiotics such as aminoglycoside, tetracyclines. Apart from that, just right there, lithium also prolongs the effect of muscle relaxant. Hypothermia and acidosis. These are the most important ones, guys. Hypothermia, acidosis, antibiotics such as aminoglycoside, tetracyclines, and lithium will prolong the effect of muscle relaxant. Hence, they are avoided. If you are going for general anesthesia, you are avoiding this. Okay, guys? Okay, thank you.